Thank you very much for the opportunity. I think the topic of cystic fibrosis was picked because this is a disease where the multidisciplinary team approach was applied many years ago, which have shown a significant improvement over time. And in this approach, the nursing was the vital part of the program. At the same time, this is a disease which have transformed over the last 50 years. And with the approach of not just physicians, but number of other members of the team. And that's why it is a little important to mention the progress and to appreciate the work which was done by the nursing over the years, which have made so much significant change over time. I have no conflict of interest, except that I just had a coffee outside. All right. First of all, we'll just briefly go over what the cystic fibrosis is and how it has been over the years to have a little idea what we were and we are dealing with. Cystic fibrosis is the most common life-shortening genetic disease in Caucasian, with about 35,000 patients in the United States and almost about 75,000 worldwide with this diagnosis. It is present in 1 in 2,500 live births in Caucasians and about 1 in about 20,000 in African Americans and about 1 in 70,000 in people from the Asian heritage. It's a autosomal recessive disease with the chromosome 7 being involved. And what it does happens is that this is a defect which leads to the abnormal protein, which is called CFTR. And this protein is responsible for moving the chloride through the cell membranes. And as that is defective, the sodium and water don't follow. So what happens is across the cell membrane, on one side there is too much fluid, on the other side there is dehydration or less fluid, so the secretions on the other sides become dry and thick and cannot move well, and that leads to the to more viscous secretions in different areas, leading to secondary infections. That may be lungs, that may be GI tract, that may be sinuses, that may be a number of other areas where this protein have effect on movement of the secretions. It is more than 2,000 mutations have been identified, and delta F508 is the most common one. The diagnosis of CF usually is very simple, but at times can be complicated. It's usually the clinical presentations, GI or pulmonary disease, or a positive newborn screening, which is now being applied more frequently in many states in the United States and in many other countries too. And also evidence of abnormal CFTR, which can either be a positive or what we call abnormal sweat chloride test, or to disease-causing mutations, or if that is not very clear, then usually the elevated nasal potential difference. We can all discuss in those things in detail if any questions are at the end. But as I mentioned earlier, usually what happens is that if this is a cell membrane, and over this side, if you take as a lung epithelium, and here is the inner side, the chloride ions move, and this is a CFTR protein. It takes the chloride to the other side, in which leads to the more sodium and water following the chloride. So the secretions in the airways become more watery, and that can come out with the cough, and lungs become stays clear. But in the absence of that protein, as the sodium chloride and water cannot go on this side, the mucus become thick, and so the cilia cannot move the mucus out, and that leads to the colonization of the different organisms into it, and the inflammatory cascade, which leads to the respiratory problems. And just an example, secretions become so thick that this is a respiratory secretions from a patient with cystic fibrosis compared to the normal person, and I don't have to mention that there is a significant difference. So with the thick secretions, as we breathe different, in the air, there's always different organisms. So those organisms settle in the airways and leads to the inflammation. First of all, in the initial ages, the multifilia, influenza, and staph comes in, then MRSA comes in, and then later on Pseudomonas is the big guy. When it comes out, it just eliminate most of the other organisms and become the dominant organism, and then that leads to the inflammation and infection and bronchiectasis and the progressive loss of lung functions, eventually leading to the respiratory failure. Now, and that's what happens. This is the bronchiectasis in a patient with cystic fibrosis, leading to the progressive loss. And once the lungs are taken out, this is how they look. This is the mucus plugging the airways, and this is the loss of the lungs because of the inflammation and the infection and the pseudomonal infection. So the key is that even if we treat that, it doesn't cure, because this is a colonization. You can only decrease the colony count. You cannot eliminate the infection. So there is a chronic inflammatory process going on, which no matter how you treat it, with the time leads to the increasing and worsening lung disease and leading to the pulmonary failure. But the CFTR protein is not located in the lungs only. It is present in many other parts of the body. The only reason cystic fibrosis is associated with the lungs is because that is the most common cause of morbidity and mortality. But if you look at the other systems, CF leads to the nasal polyps, chronic sinusitis, of course bronchiectasis, then the liver disease, because pancreatic duct is also involved. That's why the pancreas get autodigested. So almost half of the kids, by the time they are 18, they develop insulin-dependent diabetes. They also, as the enzymes which are responsible for fat absorption come from pancreas, as they are not present, they got fat malabsorption, steatorrhea, and chronic failure to thrive and chronic diarrheas. And also the fat soluble vitamins cannot be absorbed. So vitamin A, D, E, and K deficiencies kick in, which leads to night blindness and bleeding tendencies and other complications. And as spermatic duct is also affected because of that. So most of the males with cystic fibrosis are infertile. They can have babies, but they cannot move the sperm to the right place. So artificial insemination is still the way to go, but with the normal process, they're usually infertile. All right. Now, with the chronic involvement, this is the clubbing from the chronic hypoxemia, which happens, which is in the older patients is kind of quite diagnostic. Now, the treatment based on early intervention, the earlier diagnosis, so that before the permanent lung damage happens, we can decrease the colony counts and treat them aggressively with either frequent chest therapies, the pulmozymes, which decreases the viscosity of the secretion so it can come out and fast, and the hypersal, which have the same purpose, similarly maximizing the nutrition, and aggressive antibiotic therapies, and optimal physical activities to make sure the lungs are working well. And with the time, if nothing else fails, then the lung transplantation. Over the years, a lot of the research has been done, and a lot of new therapies have been introduced, which led to a significant change in how we used to treat this disease or how we look at this disease. And this is just one simple way to say it. In 1940s, before the antibiotics and the other medications were in place, the average lifespan of a patient with cystic fibrosis, unfortunately, was not more than 2-3 years of age. It has slowly improved, and over the years, because of the multidisciplinary approach involving the families, better treatment options becoming available, addressing the disease, finding out why the problem is, addressing those, eventually led to the significant improvement. And now the average lifespan is about 41 years. In fact, this is 2000, and this is a few years ago. Now it is 43 years. And it is keep on increasing. And currently, the concept which is developing now is that cystic fibrosis is no longer a pediatric disease. It is considered an adult disease. So by the time the kids are 18 or 21 years old, it is assumed that they should have a normal lung functions. They should be doing no different than any other kids. They should still are on therapies, but with the good adherence, their lung function should be preserved. And now the most common things we look for them is, do they have osteoporosis? Do they have diabetes? Do they have, how is their marriage lives are? And those kind of things, which about 15, 20 years ago, when I started the medicine, we were not even in the discussion, because we wanted to make sure that these kids can go to school. So now the things have changed so much that that is not even a question anymore. And that have happened because of the multidisciplinary approach in which the families were involved. So we don't treat the patients, we treat the families. So if the families are involved, the adherence is better, they trust their healthcare providers, and they get involved with most of the research projects which comes in, the new medications, the new therapies, and those therapies get approved fast, and they are available for everyone, and that slowly changed the whole pattern of the disease. Now, with the same slide, as you can see, the airway clearance concept was developed in around 60s. Then the anti-staph antibiotics were introduced. Later on, the anti-pseudomonal antibodies came to existence around 50s. And this is around 90s. That's when the mucus thinning medications were approved, and the inhaled antibiotics came in. And now the things are getting even better, because now we are in a process of research phases where we are developing the medications which can modify the genes. So the basic defect which caused the CF can be reversed as early as possible, so that the disease can be controlled even before it can present with clinical symptoms, and we can preserve the lungs before they get damaged. So those things are in pipelines. Some of them are in last few years, some of them have even been in a clinical practice. For example, for the mutation, the gating mutations G551D, the target medication which is called Evaceftor is now clinically available and have shown a significant clinical improvement in patients who have this defect. The other defects like delta F508, there are at least 4 or 5 molecules which are in stage 3 clinical trials. In that case, that they may also be available within the next 2 to 3 years. One is already available, but even better ones are coming up in the next 2-3 years. And they have shown that they are not only can delay the disease progression, that they have ability even to reverse what is already been damaged, both in sinopulmonary disease, the liver cirrhosis, pancreatic disease, and even the CF-related diabetes have been reversed by the use of these medications. This is one of the studies we published last year by using Evaceftor. And as you can see, this is the patient who have significant mucus plugging in different parts of the lungs. And after 1 year of therapy with the medications, the mucus plugging was almost completely resolved without any antibiotic therapies. Similarly, this is the bronchiectasis, which have developed over the years. But when the therapy was started, this was significantly reversed. This is a sinus disease, a mucus plugging, complete pacification of the sinuses. And without a sinus surgery, after about 1 year of therapy, the sinus disease was getting reversed because the CFTR mutation was controlled, so the hydration was improving, so the secretions were improving, and that led to the decreased colonization and increased ciliary function. So that is also all a positive thing, with the hope that in next few years, probably CF will be the disease of the past, in such a way that the kids who were born will be given one tablet once a day or twice a day, so that their disease, their gene can be revised or modified in such a way that they don't develop any effect of the CF in any of the body organ systems, and they can have a normal life without any kind of residual effect. That's the goal, and I think with the research which is going on in next 10-15 years, that can be achieved. Currently, the patients who do have progressive lung disease, by the time their FEV1 is around 30%, that's when we advocate lung transplantation, because the average lifespan of the patient with the FEV1 of 30% is about 2 years, and the average lifespan after transplant is about 5 years. So they have a benefit of survival with the transplant if it's done around that time. So that's when we is the usual effort. This is the patient with the severe lung disease, bilaterally referred for the lung transplant, and this is her lungs after the transplant. So the success of the CF is not dependent on one person or one physician, because that concept was history, something which we used to do 50 years ago. Now it's a multidisciplinary team, and which involve the families. We have the nurse coordinators, the dietitians, the therapeutic therapists, social workers, pharmacists, and as a part of the team. And with the nursing being the vital part, because they communicate with the families. That's how the confidence is developed. That's how the communications is maintained. That's how the trust is maintained. Because, as you know, the kids or any patient, if they will not going to take the medicine on their own, you have to have someone to convince them to do things, especially if you're dealing with a chronic disease. It's not the CF. It's the same thing you have with asthma, with sickle cell disease, with diabetes, with any chronic disease. It's very hard to convince anyone to take the medicine for the rest of their life. And they usually stop doing it when they feel better. So you have to have a teamwork to convince them that that is what they need. And you cannot convince them unless, if they're a child, unless you convince their moms. Because if the mom is convinced, no matter what you do or what magic you do, she will not give the medicine to the child unless she is convinced that the medicine is helping. So that's where the family medicine comes in. That's where the family nursing comes in, to develop a bridge in such a way that the patients get the medications or get the therapies or get the treatment they need with the confidence that something good is being done, and the parents are involved in the care. So that's the whole concept, and that's whenever there's a new therapies comes in, new research comes in, they will not going to be enrolled in the studies unless they are confident that that will going to benefit them or somehow benefit others. And for that, you all need the families to be involved. May it be mothers, may it be girlfriends, boyfriends, may it be parents, may it be children, may it be grandchildren, whoever can convince that person. Because it's not only pediatric, geriatrics have the same thing. Unless the family is involved, nothing will going to happen. Similarly, in our age also, if I'm not going to take a medicine, if my wife is not on board, and she will make sure I take the medicine, even if I'm bored or not. So, so I'll rest my case here. Thank you very much. Any questions?